to introduce our distinguished panelists.
Thank you, Wafa. I think today is going to be a very special day for many of us living with HIV and those who provide services to people living with HIV. 2 years ago, I attended a treatment as prevention workshop where there was a debate between UNS and the late Hugh Langer, where there was the key issue was treatment as prevention, something that should be promoted or not, and early initiation. It was supposed to be a fun debate, but it got very emotional with Hugh, insisting that treatment as prevention should be promoted, and Yon's getting very emotional that we shouldn't initiate people early on treatment. So to hear this pronouncement that it is now indicated that people living with HIV, regardless of CD4, should be initiated on treatment, not only shows the seriousness of those results and the study, but the urgency with which we will need to obviously implement the findings of this study. It is now my honor and pleasure to introduce the very powerful panel of eminent individuals. And I will start by introducing, and I will introduce them as they speak. Our first panelist is Ambassador Deborah Birx, whom I've now come to know as not only an ambassador, but as a patient activist in our own right. Ambassador Birx is the coordinator of the United States government activities to combat. Oh, she says I shouldn't introduce her high profile.
I don't want to waste time because I know you might have questions and I want to hear from the other panelists, so if that's okay.
I will shut up.
Okay. No, because time's a ticking for all of us to implement START. So just to be very brief on the body of evidence. So I just want to thank again ANRS and Jean-Francois Debozy and Tempano, as well as Drs. Fauci and Differbach for funding START when that question was really there and really doing it so importantly, and for the body of evidence that continues to evolve from HPTN 052. I think we heard this morning about the advantages to your reservoir if you're treated early. So we have 3 studies and clear scientific evidence. And we have a study that was stopped quickly and early, just after 3 years. And when you talk about the human cost then, 5,000 patients about, if we just start rounding. We have 20 million people awaiting treatment. When you start doing the multiplications, it's hundreds of thousands of events. Hundreds of thousands of events that could be prevented month after month, day after day. And so when the START information came out, we immediately cabled, I'm part of the State Department. We use cables rather than emails. I still don't really completely understand it, but I love new cultures. It's a cable culture. So we immediately cabled all of our ambassadors, because our ambassadors have really been very critical in all of the work we've been doing over the last 12 months on this pivot, have great relationships with the foreign ministers, with the presidents, and with the ministers of health. And we immediately cabled them the findings, because there will be a health diplomacy piece of this to translate these findings into programs as rapidly as possible. And so I guess as I called for in just a few moments ago, we have to plan now for what WHO has made very clear to us. And I don't know if we understand how far Godfrey and his team have gone out on a limb for all of us sitting here, for them to preview what they're going to say in September as rapid advice and clearly in December. But they've made it very clear to us what they're going to say. Very clearly have said it. So I think all of us have a moral obligation now, because the events are ticking. Kaposi sarcoma, pneumocystis pneumonia, TB, every day, that we need, and we have that obligation, and all of you as scientists, as program individuals that have access to ministries of health and ministries of finance, we need to, at the end of this week, go back, discuss these results and the normative guidance that is going to come from WHO in a matter of days, not months, and be ready for this change as it is implemented. We want to be part of that. We want to support it. And I just have one last comment. about men. You know, when a man comes into a clinic and finally gets all of that initiative to be tested, and we say to him, oh, you're HIV positive, but you don't need anything. Now, men are very concrete in their thinking sometimes, and so when they hear HIV positive, I don't need anything, you can see that they disappear back into the communities within their head, I am fine, because if I wasn't fine, the people I saw in the clinic would have given me something so that I would be fine. And so for years, we've been turning, after the difficulty of finding the men, we've been turning them back into the communities while we've been offering women B+. And so this is really our moment to make equality across all genders and to really capture the time with a number of men, and I imagine it's 30%, 40% of the men we have turned away over the last 2 to 3 years that were over 500 or over 350 that have disappeared into the community that we now can, as we find them, initiate treatment. And I hope we all will be part of that.
Thank you, Ambassador Burks. Well, you did mention what WHO might do, and it would be nice to hear what WHO would do. And the next panelist is Dr. Godfrey Henshaw, the Director of HIV and AIDS Department at WHO. Godfrey, please.
Thank you very much. First of all, let me really congratulate the presenters, the PIs, the full study teams, and obviously also those who have funded the studies, ANRS and NIH foremost. We, of course, are equally excited as everybody else here in the room about the findings. We finally have the missing piece of evidence. What seemed plausible to many, what many of us were convinced would be what we're going to find, we now have the evidence. We have already learned, obviously, in 2011 from HPTN 052 about the prevention, the impressive prevention benefits of ARVs, and now from Temprano earlier this year and Start Now that confirm the benefits of improved health through early initiation of treatment. The data are very clear, and they obviously confirm the trend over the last years in moving towards early initiation of treatment. So I want to talk about two elements. First of all, what does this mean for WHO, and then what does it mean more broadly, I guess, for all of us? As you know, WHO translates science into policy recommendations. This is done through a fairly structured and systematic process, review of evidence. We use the GRADE methodology, and we have an oversight committee, which is the Guideline Review Committee in WHO. Just to give you a little bit of background, I won't say more about it. You also know that the last guidelines were from 2013, where we had moved towards 500 and some early initiation indications, B+, etc. We have actually started already in 2014 to prepare for the 2015 revision, which we are working on. We had already planned our clinical guideline review committee meeting for the first week of June. And hey, on the 27th of May, we hear about the good news. And I'm not saying we were so fast in having the meeting 3 days later. It was really an incredibly fortunate coincidence, and we really were very grateful for basically the study teams and to share confidentially with us the results of START as well. So this was taken into consideration. So here's what I can share with you at this point. The guideline development group concluded that the 2015 ARV guidelines would move towards recommending antiretroviral treatment for all people living with HIV at all ages. At this point, this is a directional news that I'm sharing with you. It will move towards this general eligibility, but it's work in progress, and we're still working to have the final meeting of the guideline review committee and the paper copy, as Ambassador Burks has been saying this morning. The full release is planned for December this year, and we're working towards an interim release that speaks at least to eligibility and probably also to PrEP earlier this year in September, October, following obviously the full publication of the START trial that we have as of today. The full guidelines, just for you to know, will include not only what to start, it will also be what to use in first, second, third line. It will also have additional clinical recommendations, as I said, for all ages, for kids. We will also have for the first time, a full recognition of adolescents, 10 to 19 years in there, etc. And there will also be what we call operational recommendations, how best to deliver the services in a range of areas. We obviously anticipate, and that's another important role that we see WHO having together with many other partners, working with countries to then act upon this policy guidance that is forthcoming. And just to really highlight that countries are not necessarily waiting for what WHO is going to say. There are a few countries that have already moved towards treat all. Brazil being certainly an incredible pathfinder and cheerleader in many aspects of the response over the last decades, has already moved to treat all. Thailand, same thing. Rwanda for its key populations, Vietnam for certain populations. So there's already this movement that has started, and countries are already moving to treat all. So let me talk a bit about also what are then the broader implications that certainly go beyond WHO. The biggest implication is that now we really have to do it. There is clearly the need for us for finding additional resources, as there will be 22 more million people. There will be the need to really think again about how to best deliver the services, thinking about service delivery models, again, thinking of ways of involving the community in the service delivery, etc. And then also how to best use the resources that we have and to find additional resources. I would just like to say two more points. One is, as we're all enthusiastic about getting people on treatment, treat all, we really, really need to get serious about testing. Because as of now, only 50% of those people that we estimate are HIV positive do know their status. And in that spirit, WHO has actually, we do have a paper copy on testing. We have launched in this conference yesterday in a satellite testing guidelines with the idea really to propose a more strategic way to testing, to ensure better quality of testing, and really moving from a we did a lot of tests mentality to we tested the right people that are most likely to be HIV positive. And the second point that I would really like to highlight is we still have 2 million people that get newly infected every year. We are very happy. We are celebrating that 2 million people got on treatment over the course of last year, but there were 2 million new infections. So we will have to obviously take full advantage of the prevention benefit of ARVs, but that also possibly means PrEP. And we will also, for the first time in our guidelines, in the ARV guidelines, have a PrEP recommendation. In the past, these were separate guidelines, but this time we really will incorporate this into ARV guidelines, and we will move towards a recommendation that recommends PrEP to all individuals who had heightened risk of HIV infection, obviously in the context of a combination prevention approach. And I will stop here because my colleagues are getting very nervous about time.
Thank you, Dr. Hisham. And our next speaker is Dr. Salim Abdul Karim, whom we fondly call Slim. And Dr. Salim is head of CAPRISA, and we would like to hear what he has to say. Thank you.
Thank you very much, Kenley. I'd like to start by extending congratulations that Gottfried has already conveyed to the researchers. I recall several years ago when I saw an email during the circle about, is the study ethical and so on. And we know that studies that are at the cutting edge are challenging to do, and because they are at the edge, they're often controversial. So I want to congratulate these scientists for staying the path and ensuring that we get these really important data. So well done to our scientists. So in looking at the data, for me, what they do is they provide a consolidated list of what we now see as pros and cons. So we've had accumulating data from observational studies that have been pretty compelling in terms of the benefit. The real challenge has been to understand what the risks were. And many of us who treat patients understand the risks of putting patients on treatment. So to me, one of the most important findings from the START trial and from the Temprano trial for that matter is the careful measurements of side effects and adverse events. And when we look across the two arms, the deferred and the early treatment arms, what we see is minimal or no differences in the adverse events. And for me, that provides a strong and compelling argument to those naysayers that have continually argued that we shouldn't put patients early on treatment because of the effects of the therapies. So to me, it lays that issue to rest and makes very clear that in the absence of those harms, the 6 clear benefits that we now know that come from early antiretroviral treatment need to come into focus. And those are, firstly, that we decrease deaths. The second, that we decrease opportunistic infections, particularly in this case, tuberculosis, cancer. We also know that it decreases bacterial invasive illness. So it decreases death, decreases morbidity. We also know very clearly that it has an impact on the health service by decreasing the big problem we have in the AIDS treatment continuum, in that our highest losses in follow-up is in pre-ART care. You already heard that from Debbie very clearly. So we will be obviating one of the biggest challenges in ensuring that the cascade is properly fulfilled. And then we have 3 benefits that go beyond the individual to the broader public health benefits. The first is we've seen very clearly from HPTN 052 the benefits of prevention. We've seen from studies like the Partners PrEP the benefits in terms of preventing genital herpes, and we know that it also concurrently, for those patients who have hepatitis B, provides treatment for hepatitis B. So these are 3 individual benefits and 3 clear public health benefits that make a strong case for going this path. So I think what we will now have to grapple with, and I will not comment on this further at this point, but in the accompanying editorial in the New England Journal of Medicine with the START paper, I present a set of arguments about the impediments and how we need to overcome the impediments to the global implementation of early antiretroviral treatment. In my opinion, it's very clear that we've reached the stage that we've got to look at the key issues and the pillars on which the response will be based at a global level. We presented this in the UNAIDS Lancet Commission. We've presented this in various UNAIDS reports, and they really hinge around our ability to test everybody, to treat everybody, to retain all of those in care, to respect everybody, to ensure that we get away from the stigma and the discrimination so that patients come forward in care, they come and are retained in our healthcare services. And finally, that the 5th of these important things that we need to do is to continue our combination prevention so that together with treatment, we can have an impact and head towards our goal of ending AIDS as a public health threat. Thank you.
Thank you, Slim. Thank you, Slim. The next speaker is Zunyu Wu. And Dr. Wu is, I know what that sounds like, but Dr. Wu is the Director of National Centers of AIDS and STD Prevention and Control of the Chinese CDC and a professor at UCLA Schools of Public Health. Dr. Wu, please.
Thank you for your introduction. I want first to extend my congratulations to the START research team for this very important finding. I want to make 3 comments. The START finding is very important. It's important to China, important to globally. Let me share with you a story About 3 years ago, we had a meeting. The meeting not like this scale. It's only about 50 participants, but a very high level. About 40 are minister or governors or vice premier talk about the national policy. One of governor from province, he reported to the premier, said, because infected sex workers continue to engage commercial sex, continue to spread a virus. One way to do that is to provide ARV for treatment, reduce the viral load, then reduce transmission. Then they propose to provide ART to all infected individuals. The premier said, that's a great idea. Can we do that? The premier asked health minister, how many people now in the China provide ART? How much it cost? The minister says, now we have about 200,000 in the ART. We have another half that's not covered by ART. Then minister asked, how much money it costs? About 700 million. If we double, the minister said, that does not cost much, that's fine. If we provide treatment, it's okay. Does the science support? Then the Ministry of Health, looking at all the published literature, there's no scientific evidence to support, provide treatment for all. Now we have evidence to support, so we could have a scientific support to provide treatment for all. It's also important globally. UNAIDS proposed to end of AIDS by 2030. To achieve that, they proposed 3 90s in order to achieve 90% of people diagnosed being treated with ART. This is very important funding to support that strategy. The second point I wanted to make, it's, as Godfrey just said, testing, very important strategy. Without diagnosis, how can we provide treatment for people infected? Yesterday, Godfrey, on behalf of WHO, announced landmark, very important, revolutionary testing strategy that will change the landscape of the global program, particularly the new testing strategy that will make more people being diagnosed, particularly people at early stage. Usually when people in the later stage, they have symptoms, they come to the hospital, they're diagnosed. So early diagnosis is very important. The final comments I wanted to make, we are so encouraged by this finding. At the same time, we must remind ourselves, with this finding, when we implement in the reality, it's not that easy. Because the study is conducted in the ideal setting. People participate, are volunteer, they're willing to take ART earlier. In the reality, not many doctors really support this early treatment, even you have scientific evidence. Not many people who infected, who want to take ART earlier. Let me give you an example for PrEP. Even PrEP works very well, very effective, reduce transmission. We have 2 studies in China. We try to provide PrEP to people who want to use that. 80% they intended to use. When we provide ARV, only 2% actually take. So that means we need to have to use more media or more channel to disseminate this result, to convince doctor community, to convince people infected. Thank you.
Thank you very much, Dr. Wu. Our last speaker is my dear sister, Kate Thompson, who is the Community and Rights and Gender Department Head at the Global Fund. Please, Kate, it's over to you.
Thank you. Thank you, Kenley. Is this on?
It's on, yes.
Okay. So Mark Dybel could not be here today, but he asked me to convey to the room the message that the Global Fund shares the huge enthusiasm that's been expressed by others over the START results, and congratulations to all of those involved, the investigators, the funders, and importantly, the participants. Since the days of monotherapy, when exactly to initiate treatment has been a big question and often a source of anxiety for many people living with HIV. And as the science has unfolded, the answers have got clearer, but never so clear as now. So this is really a defining moment in all of our history, just as 1996 was, and more recently with 052. For me, it's quite a special and emotional moment, because being back in this conference center after 19 years, when I remember sitting here and learning about the news on heart and asking myself if it meant that I was actually going to live a bit longer than I thought I would. And many of us who were here, some of whom are back in the room today, I know, were on treatment within weeks or months because we had access. So if it wasn't for ART, I'd be long dead and certainly wouldn't be working for the Global Fund. And in fact, if it wasn't for the scientific breakthrough of 1996, the Global Fund might not even exist. So now, in 2005, the question is, what will the Global Fund's contribution be to helping the world to take this newest science and turn it into realities on the ground through the programs that we fund? And we know it's not going to be simple, it never is. How are we going to leave nobody behind in our efforts to achieve 1990? The Global Fund was set up to address some of the global health inequalities to access. But unless we do things differently, there's a danger that as the START results get transformed into policy and operationalized, that access gap will actually be increased. And key and other subpopulations who are not accessing services because of legal and policy environments or other structural barriers will continue not to be reached. And encouraging healthy people to initiate treatment may be tricky in some contexts. Retention may be complex. And in order to create demand for testing and treatment, to educate, to support adherence and administer programs, community-led models will be key and will need to be brought to scale with far more investment, supported by operational research. And these community responses and the systems that underpin them will need to work in synergy with vastly strengthened health systems as well. And we're going to need to change the thinking at community level, because this is a real paradigm shift. Treatment for many of us for many years has mainly been focused in people's minds on those who are already sick. Treating people with no symptoms and who feel well will be different, especially when taking ART may be the first time that they feel unwell through the initial side effects. How can we ensure, for those reasons, that we're providing the least toxic and most easy to take drugs? And how do we bring down cost while improving access faster than we've been doing so far? How do we better focus our investments where there's the most need and support countries to adapt service delivery models to ensure that access for those communities most in need is assured? Moving forward, the Global Fund will, among other things, seek to increase investment in programs to reduce barriers to healthcare, including gender and age-related barriers. We'll continue to fund evidence-based combination prevention efforts as a key element to the response. We'll continue to promote person and community-centered approaches and to focus our investments in locations and communities where incidence and disease burden is highest. We'll focus on program quality, efficiencies, and innovative approaches. and support the generation of better data that's going to enable all of us to more effectively drive those investments. We'll reduce HIV-related stigma through supporting greater integration of HIV programs within broader health as one mechanism for doing that, and support vastly scaled up rights-based testing, done in different